Thank you all for coming to the IOP Thursday seminar. We are very excited, all the way from New Orleans, to have Augustine Denteh. And if you think I have mispronounced or misspoken his name, I have not. That is his name of choice, so don't think that I'm just not paying attention. We're excited to have him here. He's going to be talking about this Oregon health insurance experiment that I've heard a lot about, so I'm super excited to hear about his findings. He is an economist by training, so you're welcome to pepper him with questions incessantly. He enjoys that. So we're thrilled to have him here, and thank you. Take it away, Austin.
Thank you. Well, thank you all for having me here. I'm very excited to be here. So far, it's been an excellent visit, beautiful campus. Got to do a little walk this morning, and it was really great. A little too chilly for my liking, but it's better now. So I'm really looking forward to this talk. I think, this is the first time I'm giving this talk to, an interdisciplinary team of researchers. So I'm really curious about what you guys think, questions you might have about how we might improve upon this paper. The idea in this paper is very simple, as you would quickly find out. So I'm really looking forward to it. Really, the idea for this paper came as a result of two things. I was doing a postdoc, at healthcare policy at the Harvard Medical School, picked up a few, ML techniques for causal inference, and I got to Tulane and started teaching health economics. And every time I have to tell them about, well, we have all this evidence about how healthcare utilization responds to cost sharing from RAND. And we get to the Oregon and, we tell them all about the findings and also tell them, but also these people who receive coverage increased ED utilization by a lot. And this was across the board and also for conditions that you might, think shouldn't be, treated in the emergency department. Right? So I started thinking, well, could it be that there is something more to the average impact than just reporting those? And none of the previous work on Oregon, which is very extensive, by the way, has specifically looked at this question of heterogeneous effects of Medicaid coverage. So we thought, why not apply some of these tools, gain some insight into who is driving this effect, and hopefully suggest some ways in which we might use those effects. So as you see, it's pretty simple idea. So I welcome all questions, especially those that I cannot answer that concern mechanisms, policy questions. All of those are good. Well, this slide is going to be not new to lots of you. The main thing I really want to talk about here is just this final question about how does healthcare utilization change for Medicaid coverage? As we know, Medicaid coverage is an important part of this idea of achieving universal coverage. There's still Medicaid expansion that states can adopt. As of now, 12 states having adopted Medicaid, so there's room for different types of future coverage expansions, right? So, well, what do we know? Well, on the one hand, you might think, well, folks can go to the emergency department whether or not they have insurance, right? So they could do that whether or not they have insurance because they've, they are hospitals are legally required to cover them. But you might think that upon getting coverage, your out-of-pocket cost is going to be, smaller, and so you might, want to access the emergency department a little more than you did. You might also think that there's probably some substitution between primary care and emergency departments, and so you might wonder whether, emergency department visits might decline as a result of getting coverage, or you might think, well, actually health might get better, and so that might reduce the need to use emergency care, right? So there's all of these different theories about what could happen when you expand coverage, especially to a low-income population, right? Guess what? A one-of-a-kind experiment came along, which happened in Oregon, which, up to this point, which provided very new and compelling evidence about what happens to healthcare utilization and also health outcomes of low-income individuals when you expand coverage. Amy said this was a drop everything and must look into it moment. So as you know, these spurred lots of research on the coverage expansion effects of Medicaid. These are well documented. A lot of their data is public, which is really nice of this team of researchers. So, as some of you might know, but I'll quickly also just recap some of the main findings from the Oregon experiment. Within a year, those who received coverage as a result of winning the lottery, were 25 percentage points more likely to have insurance. So That's the first stage, which is not surprising. Healthcare utilization increased across all domains of utilization. In fact, in the original papers, because they had only used self-reported, emergency department utilization, that they found effects that were imprecisely estimated. But later on, once they used the emergency department data, they found this positive impact of gaining coverage. We also have some, improved health in terms of self-reported physical and mental health. However, we also, like I said, we also have this positive effect on the emergency department using admin data from the Portland area hospitals. And they found an increase of about 7 percentage points in the likelihood of using the emergency department. And also in terms of the number of visits, increased by 0.4 visits, which came out to about 40% increase, right? So as you know, these results also persisted over time. So there weren't any differences in time, long-term, medium-term, at least for 2 years. And in fact, in the follow-up paper, in the 2016 follow-up paper, they also were able to rule out some channels that you might be thinking. So if you're thinking that there's some substitution going on there, they in fact think it might be complementary in terms of emergency department use and primary care use. And so, again, so their conclusion was, look, if you expand coverage to a population such as was in Oregon, you will have increasing utilization. It's going to be across all domains, including emergency departments. And, to my knowledge, that, I don't think they offered any reasons why that might be the case. There's certainly speculations in their papers, regarding this, but nothing definitive to my knowledge. And we won't be providing that as well. We'll also show you what these heterogeneous effects are and speculate somewhat on why this may be going on. Right? So anyway, as you know, this made headlines. Steady expanding Medicaid doesn't reduce ED trips, it increases them. Medicaid expansion boosted emergency room visits. So this was all over in the media and was well covered in terms of what the emergency department implications of coverage expansions are, for good reason, because that type of care is more expensive. There's all kinds of reasons why we might be interested in learning more about this impact, right? So those were the headlines. But prior to Oregon, and in fact also afterwards, there are other studies, although using natural experiments, that actually find decreases in emergency department use. Right? If you think of the Massachusetts expansion or reform, that included some, Medicaid expansions as well, and you find, decreases in emergency department use. When you look at the young adult mandate of the Affordable Care Act, there were some declines in emergency department use as well, in a couple places, right? So, in fact, Summers and Simon talk about this a lot in their paper, and they discuss, well, Oregon is by itself in this increased, ED utilization, and all the other studies, find the opposite. In fact, you might think that the Oregon study is actually more credible because it's based on a randomized lottery, and so maybe it has more credibility relative to these other studies that are based off of natural experiments.
Well,
Tim, yes?
the ACA, Medicaid, Arkansas, and Kentucky. Medicaid pays nothing. Not a lot of physicians take it. But the ACA pays the same as the state employee, as it pays much more. So what are we looking at that decline there? Is it the ACA or is it Medicaid, or what is driving things in Arkansas?
Oh, I see. I'm not exactly too sure. I don't know exactly the answer to that question. I may have to look a little more closer at that study to exactly be sure.
If it's the ACA, fine, you can see
Right.
more physicians, you might not have
Right.
to go to ER.
Mhm.
But if it's only Medicaid, then maybe the only physician you can see is the ER. So that's what's in the back of my mind throughout this whole paper, just so you know.
Right.
But, so that, you should clarify that.
All right.
Tennessee, always a wacky state.
So it's a good comment. Yeah, and to go back on that, we don't in this paper attempt to reconcile any of these results. In fact, there's a nice recent paper by Amanda Kowalski who has attempted to reconcile, the evidence in Oregon to Massachusetts, and in fact using sort of the MTE sort of framework. And she just basically chalks it up to differences in rates. You've estimated different local average treatment effects in these two states. So again, we don't attempt any reconciliation here. Our main questions are summarized on this slide. It says, all right, so we know on average what's going on. Who is driving this positive average effect? Is it mostly happening on the intensive or the extensive margin? And are these average effects representative? Right? And this should come as no surprise. We know that when effects are heterogeneous, the average effects is not representative of the individual treatment effects. And so we've got to, in the presence of heterogeneity, we've got to look a little deeper to probably understand, which subpopulations are driving these effects, especially in the case that it has implications for policy. And I'll talk a little bit about why I think there are some potential implications that looking at heterogeneity here might lead to. Right? So it's a paper about averages, and I think all of us will be on board here. Right? All right, so what's the objective? We estimate what we call individualized treatment effects. Some people call this personalized treatment effects, whatever you want to call it. I'll talk a little about what we mean by individualized treatment effects using some causal machine learning methods. We characterize what the distribution of these treatment effects look like and provide some insights that will tell us what the key risk factors are to increased ED use. Towards the end of the talk, I'll talk a little bit about, which is something that comes up in any of my work on heterogeneity. What do we do with all these heterogeneous effects? If you've told us what these effects are, what should we do with them? And I'll tell you a little bit about what I think these process or might do. And in fact, what I'll talk about today with what we might do will not be very useful in the Oregon case, but we argue that it's actually going to be useful in lots of other kinds of Medicaid expansions that are ongoing now. So we'll talk a little bit about how to think of estimating simple decision rules, about who to assign to treatment, etc., and whether those decision rules might sort of open the door for more targeted interventions in Medicaid. So it's sort of what the roadmap is. Preview of the findings. Well, we find substantial heterogeneity. This is very meaningful. The individual treatment effects vary a lot based on covariates. And so you might think here that the ATE or the late is not representative at all. We identify some of the risk factors. We'll talk a little bit about them. We won't be able to tell you a whole lot about why these particular groups of people seem to be at higher risk of using ED. But that's going to come from gender, age, previous participation in safety net programs, and also past use of the emergency department. And you're going to see that a lot of the stronger impacts of ED use are concentrated on these covariates. And then intensive margin effects matter a whole lot. It does seem, or we have suggestive evidence that really what's happening is folks accustomed to using the emergency department who continue to utilize it even more upon getting coverage. I mean, that's some of the suggestive evidence we find, and some of our estimated decision rules, as you'll see, provide very sensible ways of targeting individuals. Any questions? Okay on. All right. So, well, to just recap and talk a little bit about the study population in Oregon, there are actually two different programs. In Oregon, the first one, which is OHP Plus, is the non-lottery program. That's the program that's for those who are categorically eligible based on federal guidelines. So these are going to be low-income children, pregnant women, blind and disabled people, and TANF recipients. So if you fall in these categories, you will be federally eligible, and you certainly can receive OHP Plus. However, the lottery program is the OHP standard, which was, Oregon's way of reaching out to, other people who were uninsured and who couldn't gain coverage through Medicaid because they couldn't qualify under the federal rules. So right off the back, the point I want to make here is that this is a non-typical group of, individuals who were previously not eligible for Medicaid. They were uninsured, low income, non-disabled adults, right? So you've got to be 19 to 64 years, be a resident, you've got to be a citizen, and be uninsured for the previous 6 months, and certainly have incomes below the federal poverty line as well. So low-income adults who couldn't gain coverage through the traditional program. This was the lottery program in Oregon. And it did provide relatively comprehensive benefits, but they were somewhat still more limited compared to the standard program, right? So, all the previous work in this area highlight the concern with external validity of the results from Oregon, and this is sort of further buttresses our point that, even more so that, we've got to be worried more about heterogeneous effects, especially because of the non-typical nature of this expansion population. So keep that in mind as we think about the coverage effects when we go along. All right. So again, just to recap and tell you a little bit about what the lottery experiment was. Lottery list was open in February 2008. The goal was to allocate 10,000 spots. And, the administrators in Oregon couldn't find a way to do it that would be pleasing to the federal government. They certainly had considered and toyed with other ways of doing so, but eventually settled on just, random, experiment. And about 90,000 individuals signed up for the lottery. Eventually, 30% ultimately gained coverage, because you've still got to meet sort of the requirements for OHP standard. So what do we do? Well, our sample is exactly the emergency department sample that was used in the 2014 science paper by this team of researchers. So this data is public. It's available on their websites, on the NBR website. There are some variables that are not available publicly, especially those from the credit report data and also some discharge data that were utilized in the first series of papers. So this is mostly going to be individuals who were in that emergency department data from the Portland, Oregon area. Right, so this is the emergency department sample. So we use exactly the same sample. We've got visit information going from 2007, before the lottery, all the way through 2009 for about 24,000 individuals. This is based on 12 hospitals from the areas, from the Portland area. So what do we do that's different with this same sample? The first thing, well, obviously, we keep all the variables that were used in that data, in that paper. Our outcome measures are all emergency department utilization measures. These are going to be 14 different measures overall, emergency department use and emergency department use grouped by different types of conditions. And whilst we don't have access to the ICD-9 codes that were used, there's already some aggregation of these different codes into these 4 different types of conditions, which we'll talk about. So we use all of those. There was some information that was also collected when you sign up for the lottery. There were 8 variables that were there: your age, household size, what language you prefer. So this is basic information that was collected on the lottery sign-up list. So all of those are also included. What we do that's different from previous studies in this area is to include 2 sets of pre-lottery variables, right? So the first one is an expanded list of pre-lottery emergency department use. And so this goes back from, I think, 2007, all the way right before you got notified that you had won the lottery. So these are pre-lottery emergency department utilization, and we include, an expanded list of variables of about 20 across various kinds of conditions, that for which you show up to the emergency department. So that's one dimension that we think will be important in terms of what your previous or historical emergency department use is. And secondly, we also have administrative records of your participation in some social safety net programs. So that will be SNAP and TANF. And again, these are not subject to any misclassification because they are from the state administrative records. Well, I should qualify that. They're certainly better than self-reports of participation. It's not exactly true that they are completely free of errors, but they are certainly better than using self-reports. And so we include that as well because, again, that proxies, I think, for your previous interaction and experience with government programs, and those may be correlated with other factors that we don't observe in the data. So these are the two main variables, and there's not a whole lot of other variables, but I think these two dimensions are pretty important. In the Amanda Kowalski paper I referenced, they had also used some previous emergency department use, but not the pre-lottery SNAP or STANF participation. So once you limit the sample to individuals who have non-missing data on this additional expanded list of variables we have, our sample is pretty similar to the science emergency department sample. In fact, it's only different by about 30 individuals, which has, I think, very negligible, impact on our estimates. In fact, we can replicate very closely the results in the original science paper. So that's good to know. So that's what our sample is, the ED sample, just augmenting the set of variables for exploring heterogeneity with these set of variables. Okay, so definition of treatment effects. What are we going to be thinking of here as our treatment effects? In the paper, we do both intent to treat effects, but for the purpose of this presentation, all of these will be coverage impacts, which means effects of gaining coverage. So these are going to be local average treatment effects. The only thing that's going to be different is these are going to be conditional on the observed variables that we include in the estimation, right? So, you can think at the lowest level, if you use all observed values of each person's covariates, you end up with what you might call the individualized treatment effects. And we are already very familiar with group or higher levels of group average treatment effects. So if I estimate effects for SNAP, previous SNAP participants, that's at that level, it's a higher level of aggregation, and those will be sort of your group average treatment effects, right? So, the flexibility with some of these methods is you can estimate these effects at the individual level, and then you have flexibility to determine what level of aggregation you end up reporting your results, right? So we'll show some results that will include the entire distribution of the individualized treatment effects, and we'll also show some results that aggregate some of those to some higher level. So this is your usual late parameter interpretation is, exactly the same, except you are conditioning on covariates. So that's about 35 different variables that we use to explore heterogeneity, and those would just be your previous EDU's measures as well as SNAP and TANF. Right? So the instrument here is obviously whether you won the lottery or not, and the treatment here is Medicaid coverage. Right? And the certain variety. Yeah.
What exactly do you mean by Medicare coverage?
Right, so the first step is you get notified that you won the lottery, and then you submit an application, and if you are qualified, you get to be enrolled in Medicaid to receive.
You automatically are enrolled.
You're not automatically enrolled, you still got to apply and qualify,
Okay.
even upon winning the lottery. So Medicare coverage just means that individuals who won the lottery and eventually got covered, which means they were eligible.
Yeah, I'm thinking about this issue with Medicaid that you can enroll ex post after you go, but I guess that's not true with this.
Well, yeah. So
It would be true with experimental samples,
right.
So it's not a concern.
Yeah, well, the way I think I see what you're raising. The way Medicaid coverage is measured here is if you've received any Medicaid in the period after you are notified. So in the post lottery period, if in that entire 18-month window, if you've ever reported, if you ever show up on the state records of having received Medicaid or having been covered by Medicaid, then you show up as treated. So you show up as receiving coverage. So it sounds like what
there
just
could be people that needed it, so they never received Medicaid, but they're treated.
right. I suggesting that there could be people who get covered later, but were not lottery winners, and so they could. No.
I'm worried about people that were lottery winners, never actually signed up, but they knew that they were eligible and could sign up if they want to, so it's going to change their behavior.
Okay. So there's some people who won the lottery, knew they'll be eligible, but eventually didn't.
They never got sick, so they never bothered to fill it out. But they
Right.
would've-
Right. So yeah. So those people wouldn't show up as. Yeah. So if they've never gotten covered, then those people will just show up as, untreated in this sample, because there'll be no records of them ever receiving coverage in their entire post-lottery period. So yes, there are some of those people, they will never be counted here as treated. I don't know, does that have any implications for, I think, estimating coverage effects here, I think? Because we are ultimately interested in those who got covered by Medicaid as a result of winning the lottery. If you think of the late. So if you eventually don't get covered, I think that's still fine for the estimates we have here. Does that make sense? I mean,
It's sort of, yeah, it's a question of how you define the treatment.
right.
Things right? You might think of eligibility as the real treatment,
Huh. Okay.
as
So
opposed to actually receiving Medicaid.
right, I see. I see. So then in that case, you might be. So the ITTs the intent to treat effects will be, might be. Well, maybe not, because it's a different intent to treat. Yes.
One is you never bother to take it up.
Right.
And that's sort of like, and then another one is because you turned out not to actually be eligible.
Right.
And those are-
Yes, those differ. Yes. Okay, now I see your point. Yes.
There's not the extreme, a little bit more extreme case that you get lotteried and then you sign up at the hospital. There's nothing like that, right?
I mean, I think
That's
that's
what I was asking, yeah.
right.
I go to the emergency room, and when I'm at the emergency room, then they sign me up.
Well, then you show up. Then you show up.
That happens
That's
in lots
possible.
of.
That's possible. Yes.
But can that happen to the ineligibles in Oregon? The ineligibles, the ones who didn't win the lottery?
No.
They can't. Okay, that's the key.
Well, I mean, wouldn't it be, so if they became eligible because they were pregnant, as an example, then somebody who didn't win the lottery could become eligible for
Right.
a different reason?
Right.
Different reason, that's real.
Right.
Right. Or, like they
Right.
have a disability, but they
Right.
don't meet disability determination criteria
Well, you-
during their
well,
first round of application?
If you could become eligible for SSI, for instance,
Right,
which would would get you in,
Yes.
despite the lottery.
Right.
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 There's a lot of SSI in Oregon, a lot of it if you read that New York Times writer.
Right. And so to follow up on that, yeah, so actually in that case, if you became eligible in other ways and actually get up covered, even if you got covered for the original, the traditional OHP plus, you still show up as treated here. So, I realize that means you've got to be, it changes sort of how you think of the interpretation of the treatment effects here, but that's standard, and that's what all the previous work on this area has done. If they report coverage effects, their coverage effects for anybody who shows up covered in the post period, whether or not it is for the lottery program or not. So that would certainly include, which is a good point, would certainly include people who got covered, didn't win the lottery, but became eligible in other ways categorically. And even if that's the standard program, that's still treated here. So that's a good thing to keep in mind for.
And just to Chris's point, I think it's relevant, as minor as this is, what the messaging was about having won the lottery, right? Because it makes a difference if you're told you are now going to get Medicaid, versus you still might be eligible, come sign up and see it. Like, because states kind of often put cushion in where they're not actually telling you won, but they're saying that they think you won and you should come find out. So I think actually knowing what the messaging is really
Right. And that's what initially, I was also thinking about this initially, and I thought, I could make the case that this is actually a case of one-sided non-compliance, where, if you didn't win, that you couldn't get it, that's actually not true. Because that will actually change the interpretation of our effect here, that those may actually be treated, treatment effects, average treatment effects on the treated, right? So, but yeah, there's I think, two-sided non-compliance here. So these are indeed local average treatment effects and may not be ATTs. In fact, we're going to make that point. Actually, these treatment effects actually have sort of a more a wider interpretation, maybe ATTs, but no, there's non-compliance potential on both sides. Yeah, that's a really good distinction there to make. So we use causal forests. I have been told, based on some of my previous experiences, that folks here are very familiar with ML methods for causal inference. I mean, I like these causal forest approach because they are, if you are not familiar with causal forest, they are non-parametric estimators of these sort of conditional effects. They've been extensions of the typical random effects for prediction problem that has been adapted for causal inference. The only thing that changes here in terms of how these forests work is, in the usual random forest, you target heterogeneity in the outcome. So you are worried about predictive accuracy, and here you're worried about targeting differences in treatment effects across different subgroups of the covariance space, right? So the idea is, find those, partitions in the covariance space where the treatment effects, are largest, are different. So it's a very high level overview of this. I mean, and so the causal trees, which came first, simply maximized differences in treatment effects, and those were further developed into this causal forest algorithm, which takes all of these inputs of things that you think matter for heterogeneity and simply split on them recursively and end up with sort of a non-parametric estimator of what these effects are. So what these sort of quantities are is, once they are estimated, you can feed in new data, and it will be able to predict for that new person or individual what the local average treatment is for that particular person. So when I show you the graphs, we're going to be ending up with about 24,000 conditional local average treatment effects, because these are conditioned on each of the vector of covariates for each person. Right. So that's about what I will say about these these methods. We grow very large trees, 100,000 trees. Standard errors again still are clustered at the household level. How these get aggregated is what's called a doubly robust fashion instead of a simple unweighted average. But this just has more desirable properties than simply just averaging them in an unweighted way. But papers on this have enough details, and if you want to talk a little bit about those, I'm happy to talk a little bit about those. All right. So some results, finally. So I'm going to show different sets of results. They are going to first mostly be on the extensive margin. There will be some on the intensive margin, but the pictures and graphs I'll show would mostly be on the extensive margin. We report intensive margin effects in the paper. We also have in the appendix ITTs, intent to treat effects as well in the appendix if you want to look at those. So I present a distribution for overall EDUs, outpatient, those that result in hospitalizations, inpatient EDUs, and we'll show some aggregate effects, both using the non-parametric method, but also doing for the linear IV method we'll do. And we show you what's important for heterogeneity. I'll show you some characteristics of people and some selected group level effects. And at the end, I'll talk a little bit about some policy learning exercise we do, which is heterogeneous effects. So this is the main results graph, which is going to be showing a histogram of all of the individualized treatment effects. In the lighter shade is just the raw distribution of the treatment effects. And because we're thinking about capturing some sense of uncertainty, we decided to superimpose the distribution of the individual treatment effects that were significant at 10%. You can do it at which level? Because remember, for each of these individualized treatment effects, you also got a variance estimate and standard errors to go with it. So you can do inference in that way. And so we're kind of thinking of a way in which we can kind of show both the distribution, but also some measures of uncertainty. And this is what we came up with. And what you see in that blue shaded area to the right is all the ITEs that are significant at a 10% level.
I'm sorry, I don't understand what this is. So this is, each observation is what? What do you mean by an individualized treatment effect?
Well, each observation is each enrollee or each person in the Oregon experiment, but you've got a local average treatment effect for each value of the covariates. So if they are male, you've got 1 or 0 there. If whatever all the values of their covariates are, these effects are estimated conditioning on those. So if you think of the way in which we would have, estimated other kinds of heterogeneous effects, you might estimate a heterogeneous effect just for males, right? So you've aggregated everything and just for males, regardless of, in fact, marginalizing across all of their other covariates. But now we are, in fact, estimating those for each EXX. So for me, I'm going to have an estimate of this tau x, which is going to be exactly based off of my own covariate values. You would have a different tau x based on exactly the values of your covariates. And actually, what's interesting, which is a point that is worth making, is you could end up with the same tau x for 2 individuals, and although they are different, they might have different covariate values, but you could end up with different tau x for them.
But
Right.
each treatment is there once, so like each box on the histogram is one.
Yes. That's a histogram of the 24,000, whatever, just a histogram of the 24,000 ITs. Yes. Yeah, so this is why they call it personalized treatment effects. We call it individualized treatment effects. People differ in terms of how to call it, but the point is that it's the level of granularity that matters here. Are you estimating just at a higher level of X aggregated to some, level, or are you doing at the finest, level here?
I would have thought that there's some people based on their X's aren't eligible. Is that, and if that's the case, then you're divided by 0 for those guys.
Based on their X's aren't eligible. Well, remember the X's here are only going to be the variables that we use to explore heterogeneity.
It's not all the variables that determine eligibility.
Yes, exactly. And that's a nice feature of this method, is you can decide to separate which covariates are used for what they call orthogonalization, which means if those are needed to get identification, you can kind of separate those from those that you want to explore heterogeneity on. Right, so you can specify the explore heterogeneity on these set of covariates, which is the 35 one we put in. In fact, those don't include any variables that get at eligibility at all. These are mostly pre-lottery emergency department use or pre-lottery SNAP or TANF. So mostly those. And some of the other.
And the issues for the controls, you don't know whether they would actually be eligible or not. So you can't just throw out ineligibles.
Yeah, and it's, I think it's also sort of hard for us, or at least in terms of the data limitations, to figure out who is eligible or not eligible. We've, in terms of what you fill out the application, I won the lottery, here's my application. In terms of all the information that's provided to determine eligibility, we don't know. We certainly know that if you got covered, you likely were eligible, but
you don't know for the controls.
Right. So, again, it's, yeah, please.
I've never used this approach.
Right.
The individualistic effect.
Yeah.
I'm trying to wrap my head around a couple of questions.
Yeah.
One is, how different should I think about this approach from like a predicted probability based on the data from the covariates interacting with treatment? That's one question. That makes sense. It might not. The
Well,
second question is, what if there are interactions among the covariates, which is male acts this way, but a race and male acts, yeah.
Right.
Those are my two
So
questions.
if you think of how you might do, and forgive me for going back to this simple example, but if you think that you might want to explore heterogeneous effects by interacting X's with treatment in a linear regression model that's meant to kind of recover some treatment effect, you are in effect, constraining the form of heterogeneity that's possible or that can be recovered, right? So those interactions, provide, if you do a fully saturated model, if you split by those X's or you fully interact them, you get estimates of, conditional average treatment effects. And you can, in fact, plot these from such a model, That's a way to get conditional average treatment effects, except you've taken a stand on how the heterogeneity arises. The causal forests proceed by saying, we've got 10 sets of variables to work with. We don't know a priori how they impact your treatment response, but we're going to search for where the heterogeneity is in that covariate space. And the way we are going to do it is in a very greedy approach. If you're familiar with how decision trees work, for each covariate that you provide me, and for each value of the covariate, I first begin to split on that and compute my treatment effects. And then I do that in a recursive way, in a greedy way. And if I see that there's enough, I've improved upon whatever criterion I set out, then I split on that particular covariate and that particular variable. So implicitly, we are considering all interactions of all the covariates, but never actually do them because not all of them lead to enough differences in treatment effects, and so we don't have to consider all interactions. So the decision tree picks up on interactions that lead to the most differences in treatment effects. It's one way to put it. So if I don't know whether male interacts with previous SNAP use, I don't have to worry about it, because if indeed that interaction is possible, it would figure out which to split on first, and it might split on that second one as well. So that's why I always show the variable importance. That tells me how often variables get split on, because that's an indirect way of kind of getting at what is really driving the heterogeneity here. So it is that interaction model that we just talked about, only doing so in some non-parametric way, which is using the forest.
Thank you very much.
Yep.
That helped me.
Yeah, so imagine, we actually consider doing that. Take any, we don't actually do this, but take any, you can take sort of the late or any linear way of thinking about treatment effects and kind of compute the same, conditional effects and plot them. And I bet they'll be different from this, but you could certainly do that. What we do show is, though, some of the higher aggregate treatment effects, if you did that for the linear IV, and we'll show you how some of those higher aggregate effects differ. Right, so what's being shown here is just a histogram of this is an empirical distribution of those ITEs. And, again, what's interesting here is your local average treatment effect gets you to about 4.5 percentage points there. And onto the right of that zero, you've got treatment effects that are, statistically significant and positive, right? So, this is part of why we say, well, there's some high ED users that sort of drive the average effect. Of course, there's some negative or reduction in treatment effects, but as you can see here, a lot of them are not significant, right? So you still end up with an overall positive effect on average, but this gives you a better sense of what's going on here. So actually, in the paper, we talk about the treatment effect being driven by about 14 or 15%. That's just the ratio of the significant treatment effects here compared to all the other sort of ITs. Right, so the point of this is there's heterogeneity. If you think of these sort of individualized treatment effects in Medicaid's impact, it's still positive on average, but there are some high users in the right tail that drive this effect. And this picture is not different if you look at the overall or the outpatient, so this is going to be pretty similar to what's before. Where things differ is where you don't find an effect on average, which is inpatient ED. So in the original papers, no impact on average, but that's because there is some sort of masking of these two effects where there is some positive effects, a little, there's some actually a little bit more in terms of significant reductions in ED use. Those average out to an impact that is not significant on average, right? So there's some people who reduce inpatient utilization. There's some who increase it. On average, this is what you get, and which we already know. If you've got a zero effect on average, it is likely just masking different responses in different covariate spaces, which is what we see with this particular inpatient ED graph. And if you still split by different types of conditions, we continue to see that. Everywhere where we find no effects on average, we see this distribution of strong reductions in ED use, increase in ED use, that always average to zero effect on average. Whenever there's a significant increase in ED use, there's always this sort of darker, stronger, response on the right, which then sort of lead to a positive effect on average. And so there's certainly negative effects, they're just not statistically significant. So I think in terms of aggregation, they don't end up to matter a lot. So this is sort of what our main sort of set of results are. There's a lot of heterogeneity, sometimes masking reductions in EDUs, depending on what outcome you look at. And so the next stage is then, what if we aggregate these individual average treatment effects to some average, which is the overall average for the entire sample, right? So we do that both for these linear ones we compute just using the usual, IV estimates, and these are based on the forest. So the aggregation is not a simple average, as I described earlier. It is some sort of doubly robust aggregation that's happening here. I'll try not to make a whole big deal out of some of the differences on average between the forest and the linear. What stands out to me is that there's certainly some reduction in the magnitude when you aggregate these sort of ITEs from the forest to the average. And now that's happening only on the extensive margin, right? If you go to the intensive margin, there's not a whole lot of difference when you see what those averages come up to be for the forest and the linear method, right? So it's also not unsurprising because, of course, you lose some significance, but that's also because non-parametric estimates are also going to be less precisely estimated. The takeaway that I want to make from this is, well, on the extensive margin, there is some sort of weakening of the impact. It's still there, it's still positive, but there's still some weakening there, not a whole lot happening on the intensive margin. This, in addition to other evidence, will be leading us to suggest that potentially, if you believe the forest-based estimates, that a lot of this increased utilization is probably coming from the intensive margin and less so from the extensive margin.
It's a different way. My intuition is that, like if I have one group that almost always participates and one group that almost never participates, the linear seems like it should put a lot more weight on the people that almost always participate. But in your thing, you're weighting them essentially.
Both of these are weighting these differently. They certainly are weighting this differently. The question is, so like if you think of a linear effect, remember that so it's partly a result of that, but it's partly also driven by the method, right? Now you might say that both of these sets of estimates should lead to the same place on average, right? You might be thinking that well, on average, if I have two consistent estimates or estimators, both of these are consistent, both the IV estimate and the forest-based estimate, then on average there should be no difference in what they recover on average, right? But remember that, and this is something that we've not explored well here, but whether the IV method, using the linear IV method with covariates, leads you to a local average treatment effect, there's some literature that says this sort of depends on how those covariates enter. If you remember the original formulation of whether I can think of the IV estimates as late, they don't depend on covariates. There's no covariates in that original framing. Recently, Timon, Solensky is doing some work in terms of thinking about, in the presence of covariates, do linear IV estimates actually recover the late? And there is some evidence that that's actually not the case. So I'm trying to make the point that you're right, that it's possibly different weighting. There's possibly 2 or 3 different things going on here. Remember that the forest-based method is also accounting for the linear, or accounting for the functional form of the dependent variable more correctly than the linear IV is doing. There is also some work about binary outcome, binary endogenous treatment, and when you use the IV method in that case. So there's probably a lot more we can say about why this seems to diverge. I agree that your suggestion is consistent with it, but my point is there's probably a lot more going on there. And just from the flexibility of the non-parametric estimates with covariates, I'm sort of slightly inclined and leaning towards what I'm getting from the forest-based methods. But I agree that's an issue. Now, these are not that different from each other statistically, right? If we see the confidence intervals, they probably somewhat overlap. And so that's why I'm making the point that, you're right. So that's what I'm saying. Don't make a huge, I'm not trying to make a huge deal. Yeah. Right. So, yeah. I mean, again, that's not too surprising because if we don't go to look at some of the smaller group averages, we will not end up becoming aware of these heterogeneous effects we uncovered. Remember, we've aggregated back to the level of the entire population sample. So again, these are two consistent estimators. They should lead to the same place. So this is actually not as surprising. The point, but again, there's some weakening there just in terms of the magnitude. We don't see that for the intensive margin, though, right? But that's a good point. In terms of the variables, sort of that matter here, a lot of these are, pre-lottery SNAP use comes out a lot in terms of the total amount of SNAP benefits you've received in the pre-lottery period. Age comes, your sum of the actual total ED charges that we observe, and then some previous utilization measures here, right? So what this means is in the Forex attempt to kind of partition the data into different places with different treatment effects is more often finding that when you split on these variables more often, you get those sort of effects being that different in different groups. So you can sort of suggest and kind of interpret these variable importance measures are suggestive of which variables are driving the heterogeneity. So in fact, when we begin to look at different group level average treatment effects, we kind of use a lot of those that show up here, kind of compute it for those. And if we go and compute it for some of those down here, we don't see anything on average for these particular groups, as we'll see. So that's another utility.
Can I ask a question?
Yeah, please.
What does the week of lottery sign up?
Can you please repeat that? What does?
What does the week of the lottery sign up?
Oh yeah, so those are indicators of whether you sign up in the first week when the lottery list was open in February, or whether you sign up in the second or third. I think there's about 8 different measures of when folks could have signed up. So when the lottery list was open in February, some people signed up right away in the first week, and others signed up in later weeks. And so that's just indicators of those.
I think that people who sign up in the first week may be like different compared to people who sign up later. People who are in like first
Well,
week.
right. So we are certainly not. What this says is that variable, whatever it captures, seems to be important for differences in treatment response. So the Forex figures out that if you sign up, I think earlier, which is the week of lottery sign up, it's more likely that the Forex finds heterogeneity by splitting on that variable. So anything here, yeah. So I mean, there's different. Again, there's a temptation here to begin to quickly pass out what a particular variable that's showing up more implies. It's really hard to say without any further investigation. Right? You might think, that's indicative of pent-up demand. Maybe that's why some people respond more to less. All kinds of stories are consistent with any of these. Remember, we are not estimating causal effects of any of these variables here. All we are simply saying is, if you estimate the causal effect of coverage, different individuals with these attributes will respond differently. So the treatment effect is not constant. And that's not new. In the local average treatment formulation, we already know that treatment effects are heterogeneous. All we are doing here is to relate them to covariates. Right? So which covariates seem to be correlated with that sort of heterogeneity.
Are you going to tell us which direction?
Yes, I'll tell you some of what this direction. Yes. Well, let's go there. Well, before I tell you that, I can also tell you a little bit about what characteristics are associated with individuals who increase or decrease. So here, all I'm doing is, if your treatment effect is positive, you are in this first column. If it's negative, you are here, right? So if you can see, these two add up to the total. So you just look at that graph and think anybody to the left of that vertical line, you are going to be in the decrease column. And again, this is just suggestive. These are different ways of showing results from this method. As you can see, folks that increase utilization are younger on average. They are more likely going to be male. Okay, you got 50% here. And in terms of the lottery sign up, actually we put that in, okay, so I take that back. So we actually put that in as a continuous instead of indicators. So those are going to be 1, 2, all the way through 8. So that, that's going to be 1.5. So individuals who increase utilization are signing up a little earlier than those who decrease utilization or who have negative treatment effects. So you kind of see, like if you look at SNAP, for example, a lot of those who increased utilization, 60% of them have previously received SNAP. So again, this is just, if I split the data based on the sign of your individualized treatment effect, what do the covariates look like across the two? That's all this is showing.
And maybe to put a point on it, it's not with regard to statistical significance of that effect.
Nope.
Which
It's
is
just,
to say that there's some large portion of this that is noise.
yes. This is, we could,
So you're probably hiding differences
Yeah,
because you
right.
can't tell, or you're not using statistical significance.
Yes.
to tell the difference between
Right.
negative and positive.
right. This is the reason why we try so hard to have a graph that includes, variance estimate, but not here.
Comment on that,
Yeah,
Jeff? Or
yes.
It's more of a question, I think.
Yeah, please.
Which is that I think in your routine, in your forest formation, you
Right.
have to tell the computer how large these splits, how many people have to be in each side of those splits as you're splitting. Is that right or is that not?
So split sample size, yes. So that gets into other questions about which of these parameters you can tune and which ones you cannot tune. Yes, there's a lot of flexibility when you begin to use this
That's
method.
not something you're tuning, you're presetting that. It sounds
Right.
And it seems like there's an implication then that you're, so when you set the sample sizes, you're also determining the power to detect effects.
Yeah, and the bigger the better. I mean, actually, a lot of those don't matter as much in my experience than setting what the minimum node size is in the final leaves of the tree. That seems to be what just matters most. If you said
Also
it's
within there must be some individuals or groups
Yeah.
who are small and they never can show up, right? Like because if you're dealing with, they show up here because you're not, this is not with regard to statistical significance, so they're in there.
Yeah.
With your histogram.
yeah. And that's why a lot of that, I mean, so you might say, a lot of these are really imprecisely estimated for a lot of those ITEs, rightly so. If I show you that same graph of 5%, that the darker portions are going to shrink a little more. It's going to be smaller. So yes, it's 24,000. So we're asking a lot of the data in some of those places that you're highlighting, sure. But it's still, that's why it's still fascinating and incredible that we still kind of get, such enough variation with statistical significance that we can get group average treatment effects that make sense for some of the groups that show up a lot, and which I'll show you next, actually. So yeah, take this table with a grain of salt. There's really no sense of significance here, so maybe it's not telling you a whole lot. We could repeat this graph, just limiting to those that have significant effects. This is one of my favorite graphs, and I'll come to you in a second. Actually, I'm running out of time. Well, so this is one of my favorite graphs because what it tells me is for some of selected subgroups that we determine based on our own choices, but also somehow based on the ranking in that graph I showed you, the bars here just represent average treatment effects aggregated to the level of the variable. So if I see prior SNAP here, this green bar tells me that the local average treatment effect for previous SNAP users is about 8 percentage points, and the local average treatment effects for previous non-participants is not significant, and it's here. So as you can see, there's about 54% who were previously receiving SNAP in the previous period, and the average treatment effect for them, averaging across all of their other covariates, right? You're marginalizing across all of those, is this number here. So you can see the local average. So a lot of these groups that we identify here, previous use of emergency department, young individuals, those who are males, have average treatment effects or local average treatment effects that are much higher than what the average will suggest. This is sort of somewhat related to the variable importance, because if they split a lot more on them, it's likely that their response is going to be higher anyway. So that's kind of related to that. There are different ways that you might think about why are previous SNAP people responding so much to receiving Medicaid. We can't tell you all that's what's the story that's going on here, partly because of data. But my sense of reading this graph is the individuals who respond most to coverage are maybe some combinations of these different local average treatments effects is fine. Individuals who were receiving SNAP, previous users of emergency department for conditions that you could treat in the primary care. So that goes to our point. These people are accustomed to using care. They get coverage. Maybe they have a perceived sense of higher access. Whatever your story is, here's where you can put in the story behind what's going on with these different attributes. They simply tend to respond more to receiving coverage. Yes. Yes.
Multiple hypotheses tested.
Sorry?
Like multiple hypotheses. Like if you under the null that they're all 0, 10% of your graph would be shaded.
So you've asked a question that I don't have a great answer for. Now, my reading of this literature is that these methods are less susceptible to multiple testing, but some people disagree. Some authors disagree. Some people think you've got to worry about multiple testing problems here and think of other ways to adjust this. These are not adjusted if you think that there are some concerns with multiple testing going on here. Again, remember that multiple testing is sort of, I think, related to specification section to some degree, which is not necessarily what we are doing here, per se. I mean, we begin with a set that's known a priori, and we say, go find me different types of treatment effects for different small groups. So, I mean, I get the point that maybe because you have 24,000 ITEs, you are wondering, there's got to be some multiple testing concern here. At this point, I'm leaning to, I don't know how to fix it if there's any, but it doesn't appear that in this literature that there is a concern that we've got to be very worried about that. But it's a good question.
Maybe you just want to know what it would look like under
Right.
the null.
Okay, yeah. Yeah, sure. Good
Austin,
point.
I see you're pounding away here, and you got this technique, and you're isolating people in patterns. Is there any chance you can get outcome data to see if you actually, by following some of the rules that have come out of this, actually improves people's health?
Yeah, it actually improves
Is
people
there-
health.
Well, you like at the end,
Well-
you want to know, is this treatment effective? Were patients satisfied? Some sort of an output measure.
Right,
because
right, right.
You see
It's-
differential use, but you want differential outcome.
We can't do that. Yes, there is a way. I don't know that we can get.
Home run if you could.
If I could, okay, yeah. I would have to talk to Amy about getting more of her data on this. But yeah, and because I think I'm running out of time, so I don't know what the
Just go.
Just go. All right, cool. All right. So no. All right. So yeah, anyway, so I'll skip this because I kind of want to see. I'll skip this because that's comparing again Forex with linear estimates for different subgroups. Some of those are very similar. I can say a little bit more about this, but I'd rather talk about what should we do with these effects to sort of end. And quickly, I think that so Fickle side, they summarize and say, well, in short, newly insured people are likely to use more care. I think what we are adding is yes, but that sort of depends on the characteristics of the coverage population here. I think this sort of deserves some qualification. Some people do at very high rates. Not everybody does. So there is some qualification here. If you just care about the average, sure, go with this. But if you think you want to look a little bit more beyond the average, then our results suggest that just looking at the average is an incomplete story. One way is you might be wondering, could we use this in other ways? And this is related to some other work I'm doing. This code is sort of suggestive that we can actually use these methods to come up with decision rules based on covariates. That will tell us what an optimal assignment is, in terms of a particular objective we might have, right? So there's work by Susan Athey and co-authors who show that actually you can come up with statistical decision rules based off of the heterogeneous effects you estimate that will tell us simple shallow decision trees or assignment rules that achieve whatever objective you set. So I won't go into details about that method, but we do use it a little bit here, right? So we set an objective for ourselves, which we said, what if the policy maker is interested in reducing, non-referred, non-emergency services, right? What we'll be calling here non-emergent care. So these are conditions that don't require immediate care. So you can think of, in terms of the classification in this paper, those are going to be headaches and other kinds of pain. And what if your objective is to minimize it? Yes, you can come up with some shallow decision trees based off of the few variables you feed it that will tell you, if you want to minimize this, these are the people that you should focus on either treating or having some additional intervention for. So because we're out of time, I'll just tell you quickly what we do. we focus on minimizing non-emergency use. We don't use all the variables there because not all of them may be at the disposal of the policymaker, so we use only 8 measures of the previous utilization, and this is the tree we come up with in terms of the rule. So this is an assignment rule. This is saying for individuals with these values of these CUVA rates, either treat them or intervene in some way, because if you do so, you are going to be minimizing your non-emergent use, right? You can think of this as a way to target individuals for interventions. So what this says is, for individuals who use very little outpatient emergency department, so less than 2, so they don't go a whole lot. But if they go, they are usually going for emergent hospital visits. So so again, we split by that and say, if that's the case, then select them, right? So what it says solicit application is just for people who don't use a whole lot, outpatients. If I still observe that when they do, they actually do so for conditions that result in hospitalizations, then focus on them, right? Those are the people that are likely to, when treated or when focused on, will reduce your ED use. And we do the same here as well. But this is somewhat preliminary. The Oregon place is not the best place for it. I think there's other places where some of these sort of assignment rules will be better used. There's necessarily some caveats because this exercise is normative, etc. But the point is that there's few things you can do once you've uncovered this heterogeneity, especially when it comes to intervening in some way.
Whether you're choosing them to get Medicaid.
Initially, that was sort of the framing that will be implied by this method, that you're choosing them for Medicaid, but obviously that's not going to happen. That's not going to fly anywhere. And hence, my pivoting to that you can target them for some innovations, right? Still treat everybody, but just, focus on them in some way if you wanted to educate them in a way.
So let me just, so then my second follow-up question is, how much better would this be than just looking at who uses emergency rooms for non-emergent needs, right? Like presumably you have all that data sitting in Medicaid to just figure out who are your high flyers and target them.
So that's a good question. Because you could simply say just target people. I mean, that's one way to use this. That's one way. I think Susan Athey would make the case that that's not likely to lead to, that's a decision rule. And I think they make the case in their paper that that's unlikely to sort of minimize what they call regret, which is deviations from outcomes when you kind of choose people optimally. So that's sort of one way to choose people. And in a practical way, that may be better, right? But there may be some theoretical reasons why we may not want to do so. But it is a reasonable first place. I don't think that's an unreasonable thing to do. You can literally just go and say, if I see people, all people who've previously used SNAP, if you are getting Medicaid, I'm going to find a way to be more, I'm going to find a way to figure out a way to anticipate that these people might have a higher response to coverage, and so if there's anything we can do, maybe that's a group to focus on. That's saying the same thing. You just don't want to do what this guy is doing, which is fine.
And then my third question, which goes back to Jesse's question, and I'll let other people ask questions. Sorry, cramming them all in. But just to go back to the this is an empirical method to find groups.
Yeah.
But how confident could you even be that if you had a different population, a different year, that you would find the same? So this drills down into it's empirically driven rather than theoretically driven.
That's correct.
You don't have pre-registered hypotheses.
Mm-hmm.
So it works for this sample really well. How much confidence do you have that you would have similar findings with different populations at different times?
My confidence is related to whether that target sample that we are talking about is sort of similar to this one. If that's very different, like for example, if you take these rules in Oregon and you go to New York or Louisiana, I don't think that this will replicate immediately. I think it's very specific to, I think my conclusion from taking a closer look at this Oregon data and the coverage effects here are, this is effects for a very selected group. In fact, this group, in a very selected place. So this is both not applicable to the wider Medicaid population in Oregon, nor is it to the entire United States. So we're certainly making no such claims. In other certain applications, this may be more useful and be more likely to replicate. For example, I'm currently beginning work looking at whether we can apply this to Medicaid managed care in Louisiana. So the state currently auto-assigns people to Medicaid managed care or to this traditional fee-for-service. And then we're kind of thinking about, is there a way that the state can assign people in a way that achieves some objectives? So there you are not denying anyone coverage. You're simply saying, instead of just auto-assigning you to different plans that may or may not work for your needs, can we do that in sort of a smart way? And that is more likely to replicate there because depending on the years of data you use, it's more likely that the next group of enrollees are going to be similar to the sample on which these rules were created. So depending on how representative the new target group is, this is going to be more likely to replicate. Yeah, please.
Doctors have ignored their concerns, and so according to their experience, the ER is the only place where they can get proper care, or at least care that they are confident about. So I guess I would be curious as to how that consideration would play a role in
Out-
making these decisions for who gets insurance.
I would say to the extent that we have any proxies of those variables. First of all, that concern is consistent with the positive effects you find here. In fact, in the paper, they note that sometimes providers may actually encourage these new recipients to go to the emergency department. Not only are they not able to provide it, they might suggest go to the emergency department. And so part of this increased use may be coming from that channel. It's speculative, but it's one hypothesis that's consistent here. So, and that's why, again, it's important to figure out what variables you can measure and the extent to which it helps or hurts any decision rule you might come up with here. And so I don't have, the answer is that's an important consideration if you're going to use any sort of different rule to sort of make these assignments, because that might lead you to assigning people to certain places that they might not be able to get access to the care they need, and so end up in the ER anyway. I mean, if that variable is unobserved and we are not able to tell the characteristics of this group of people you described, then it's hard to incorporate that sort of consideration. I mean, if you think about what all this is doing, this is related to, if I have some objective, remember now you're currently doing it, right? You're currently saying if you become enrolled, for example, for Medicaid, go to provider X. It's currently doing it. You're auto-assigning people. And in Louisiana, a lot of people end up staying there. Some switch, but a lot of people end up staying, right? So the question is, are those sort of assignments the best matches for these individuals? And we do it in a particular way now, and I think my suggestion here is that there could be other ways to consider, but not without cost, I think. Not without costs. Please.
I'm not sure if this makes sense or not, but so I'm wondering if we made a histogram of the effects, but we did it on the first stage, like their effect on enrollment. Like, would we see a lot of heterogeneity in that as well? And I guess if so,
That's interesting.
does that mean that there would be some sets of X's for whom there's actually a negative effect on enrollment, and how do we think about that?
Well, first of all, that's an empirical question I can find out just by doing this exercise where the first stage is the outcome. I mean, whether you get covered is the outcome. And we may get that everything is positive on one side, or some that, cross over to the negative side. And if we see that, then we'd really have to think about what it means for being assigned to treatment, reducing your likelihood of getting covered. That will be tough. My expectation would that those should be mostly positive.
Presumably, since you have a
Yes. But I can find out. I don't know. I mean, I can find out.
By like ID assumptions, right?
right.
Yeah,
Thank you all. Thank you all. Very good question.